All right, now I need to get a promise from this audience, and that is not for you to tell anyone about what I'm about to say, and what I'm going to say is that I think this year's conference has the best speakers we've ever had on the whole. So I'm just really excited about this next panel. And so it's just a wonderful morning that we can dive into a subject that we don't often talk about, and we can dive into it both from a personal and passionate perspective, and also from a policy perspective as well. So we have 4 panels this afternoon, and I think the format we're going to use is I'm going to introduce each of them as they come up. So it's my pleasure to introduce my good friend Danny Wedding. When I called Danny to ask him to speak here, he just said yes immediately. Didn't even have to hesitate, and I greatly appreciate that. He's joined us at the University of Missouri, and he joined the Department of Psychiatry as a professor in 1991. He's the director of the Missouri Institute of Mental Health, a renowned policy shop that's located in St. Louis. His primary responsibility is oversight of MIMH, which is a university research and policy center serving the mental health community in Missouri. Dr. Wedding is a trained clinical psychologist where he received his training at the University of Hawaii. He spent a postdoctoral year studying clinical neuropsychology and behavioral medicine at the University of Mississippi at the medical center there. He later completed 2 years of postdoctoral training work as a health policy fellow, a Robert Johnson Health Policy Fellow, where he spent a year on Senator Daschle's staff, and then as a APA Congressional Science Fellow in the U.S. Congress, and in that year he worked as worked for the Government Operations Committee in the House of Representatives. His research interests include international health, mental health policy, the portrayal of mental illness and addictions in films, and large-scale community education projects designed to alter attitudes about mental illness and substance abuse. So I want to welcome my good friend, Danny Wedding.
Thank you, Chris. I'm pleased to be here, and I think we're off to a great start. Peter's talk was spectacular, and I'm already thinking about what I've got to do to bring him to MIMH. My job, as I understand it, is to overview the mental health system in 15 minutes. And I'm going to fail, but I can perhaps capture it in the words of Mike Hogan, who headed up the President's New Freedom Commission, and there's a statement in their report that says the system is in shambles, and I think that's a really powerful and compelling statement, and I think that Peter illustrated that and gave that a very human face, and the system really is in shambles, and if the fact is, if we were to invade another country and try to set up a healthcare system for them, we would never use the U.S. healthcare system as a model. It would just be a disaster. We would know enough not to do that. So the bad news is that the U.S. healthcare system really is chaotic, confused, troubled, and ineffective. The good news is that in mental health in Missouri, we've got a vibrant, unified, and effective mental health leadership. Peter made the point that if you want to understand mental health, you follow the money. And my predecessor at the Missouri Institute of Psychiatry was a guy named George Hewlett. And George used to have my job and Keith Schaefer's. And at that time, 10% of state revenues went towards mental health. And in 1991, it became 9%. And then it was at 7% from 1993 to 2002. And in 2003, it dropped to 5% of state revenues, and it stayed there ever since. And money reflects priorities and values and attitudes, and it's clear that the state does not have the kind of commitment to mental health that it once had. To some extent, you're seeing similar trends at the national level. In 1986, mental health accounted for 8% of all healthcare spending. In 2003, it was only 6%. And so we're spending more on mental health but we're spending more on healthcare in general, and mental health spending does not increase nearly as rapidly as overall healthcare spending, in part because psychiatry is fairly low tech and there's not a lot of technology involved, and the increases that do occur are due in large part to the cost of new medications, which are oftentimes far more expensive than older medications. And there's a real debate now about whether or not some of those older medications that cost less are just as efficacious. The primary advantage to many of the newer medications is that they have fewer side effects and they're better for patients. If we look nationwide, we know that around 2% of the population has what is generally labeled as a severe mental disorder and actually use the mental health system. But if we look at people who use the mental health system and include those people who don't, we're looking at about 3% of the population. And so if you do the math, this works out to about 162,000 people in Missouri. And if you cast the net very broadly and talk about any mental illness, anything that would be included in the Diagnostic and Statistical Manual of the American Psychiatric Association, most epidemiological studies suggest about 22% of people in any 1 year have a mental health problem that would justify treatment. And so that works out to about 1.3 million people in Missouri. And that's really significant. The Department of Mental Health, according to my data, and Diane can correct this if it's not right, currently serves about 57,000 adults and about 16,000 children. And of course, that's not the entire population of people with mental illness in the state. But there are limited resources, and so tough decisions have to be made about who does get served and who doesn't. We know that nationwide we've got about 15 million people who have a pure substance use disorder not complicated by mental illness. And we've got around 15 million people who have a mental illness not complicated with substance abuse. But we've also got about 4 million people who have co-occurring disorders, and it's very clear that half of these people don't get treatment and they don't get served at all. And the Missouri Foundation for Health has done really a wonderful job in taking the lead in providing funding for Missouri to look at the problems of co-occurring disorders. But it's so easy to just quote statistic after statistic and number after number. And what we forget is that statistics are simply human faces with the tears wiped off. And that's why Peter's talk was so powerful and so compelling, is because he put a human face on some of the numbers. But what do we know about mental illness, and what can we say and just sort of capture the current state of knowledge in the field? We know that the prevalence is very high. It's widespread. It's common. It's out there. It's ubiquitous. All of us have been affected in one way or another by mental illness. But we also know if mental illness is treated early and well, that we get good outcomes. And the outcomes in psychiatry parallel those in cardiology and oncology and other fields of medicine. And a lot of people don't realize that. When I was in graduate school in the 70s, the message was that mental illnesses like schizophrenia were just lifelong and that people never got better, and about the best you could do was to offer custodial care. And now we know that people do get better and people do recover. And I think that's the most important message to come out of the President's New Freedom Commission. Recovery is possible and it can occur. And exciting things are happening in Missouri to make it occur. We also know that we've got low rates of detection and treatment in the mental health field, and we have significant disparities among racial and ethnic groups, and those disparities parallel those that we find in other areas of medicine. And we also know that mental illness results in high morbidity and mortality burden. Some of you might know the work of Dr. Joe Parks, who's doing really fascinating research and is sort of a national leader looking at the fact that people with mental illness die many years before people without mental illness, and they don't die from their mental illness necessarily, but they die from diabetes and complications of their illness and complications of the medication they take. I wanted to mention another book in addition to Peter's, and it's Evolution of a Missouri Asylum. And you might know that Fulton State Hospital was the first state hospital built west of the Mississippi. My friend Peter Vincennes has close ties to Fulton State Hospital. Felix Vincennes has close ties and has read the book, and we were talking about it earlier. And I recently had Keith Schaefer, the director of the Department of Mental Health, review this for a journal I edit, review the book. And here's what Keith wrote. He says, as in most of state mental health reforms, it took a tragic event to capture the public's imagination and spur the change that created the institution that would become Fulton State Psychiatric Hospital. In this case, Thomas Reynolds, Missouri's 7th governor, triggered that spark literally by tying a piece of twine around the trigger of his rifle and shooting himself in the governor's executive mansion in February 1844. And that sad and tragic act actually led to the lieutenant governor, who became the governor, proposing the first psychiatric hospital that eventually became Fulton State Hospital. But the book talks a lot about the treatments that existed 150 years ago in mental illness. And they were wet packs, and they were lobotomies, somewhat later on, and water treatments, and things that seem very primitive to us today. And I couldn't help but wonder if 150 years from now we'll look back at a lot of the things that we're doing now, and if they won't look just as primitive. Peter alluded to this, and I think that Descartes did a tremendous injustice to us when he talked about the mind and body and how they exist on parallel but separate tracks, and we're still dealing with the consequences of that dualism. Lord Chesterfield once wrote that psyche and soma are inextricably linked, and one can't suffer without the other sympathizing. And one of the megatrends that you find in mental health is growing interest in integrating physical and mental treatment. And some exciting things are happening around the state. Mark Scrady is here, and I know his group is very interested in integrated care. The Kreider Mental Health Center is also going to have a FQHC, a federally qualified health center, existing on the same campus and connected to the mental health center. So the person who comes in requesting medication for his schizophrenia can also get medication for his diabetes, and I'm real excited about this change, and the department has been very supportive of this. Diane and I have been involved in a variety of efforts to look at evidence-based practice, and of course the challenge is how do you promote best practices, how do you promote evidence-based practice and not stifle innovation and creativity, and so this is an ongoing challenge for the state. We know that mental health presents outside the mental health system every bit as often and sometimes more often than inside the mental health system, and corrections is the best example of that. At least 66% of juvenile offenders have a mental illness. Literally millions of jail detainees are mentally ill and are only in jail because of their mental illness. In our prisons, at least 16% of patients have a mental illness. I live with a woman who's a public defender, and she finds it outrageous, but it's routine for her clients when they're put in jail to be taken off of their medications, and they become psychotic, and they do really crazy things in jail, and then that gets them in trouble, and she can't get them out of jail because of this problem with medication. Oftentimes, mental illness manifests in our schools, and Missouri is also moving forward and looking at the delivery of mental health services in our school system. Homelessness is a serious problem throughout the state. It's a problem in St. Louis and Kansas City, certainly, And all of us have seen people who were homeless and sleeping on the streets and perhaps mumbling to themselves. And that individual probably had a serious mental illness and probably wasn't taking his or her medication. So we estimate that at least 50% of people who are chronically homeless have a serious mental illness. MIMH, the Missouri Institute of Mental Health, is working with the Department of Mental Health on suicide prevention initiatives, and suicide's the 11th leading cause of death for all Americans. And for young people, it's between the ages of 15 and 24, it's the 3rd leading cause of death. And as a parent, it's hard to imagine anything that would be more tragic than losing a child to suicide. So I'm really happy with the work that we're doing in Missouri with suicide prevention. I'm running out of time, so I won't talk too much about prevention, except to say that it's kind of a truism in public health that every dollar you invest in prevention yields $10 or $12 or $15 in savings down the line. At MIMH, we're very involved with prevention of fetal alcohol syndrome, and we estimate that every child that isn't born with FAS saves the state well over $1 million in services. And yet it's hard to quantify, because if those children aren't born with FAS, then it's hard to wrap your hands around the numbers and estimate how much we do save. But it's very clear that if as a society we are willing to invest on the front end, it will pay huge dividends down the line. But we have to have the political will to make those front end investments. I'm very proud of the fact that Missouri ranks 8th in the nation in terms of SAMHSA funding, and the only states that bring more SAMHSA money to their state are large states like Texas and California and Florida. We've been remarkably successful in Missouri, and those millions of dollars that come through SAMHSA have resulted in services for hundreds of thousands of people. And the final point that I want to make is just that we've got an election coming up, and politics really do matter. And the chaos and the confusion that we currently have in our mental health system is the result of political decisions. And so I hope all of you will get involved in the process, and I hope we'll force candidates to take a stand on mental health issues and develop policies, and that will support those candidates who come up with a coherent agenda for reforming the healthcare system, and especially the mental health care system.
Thank you, Danny, for that tremendous overview. We're going to hold questions until the end. We'll have a few minutes at the end of the panel, and we'll invite you to ask questions of all the panelists at that time. At this time, though, it's my pleasure to introduce Dan McFarland, who is the current chairperson of the Mental Health Transformation Working Group. That working group was established through executive order by Governor Matt Blunt. The Transformation Working Group is charged with the development and implementation of Missouri's first comprehensive mental health plan, and the plan is designed to create consumer and family-driven systems that address mental health needs across the lifespan, and importantly, transcend state departmental boundaries. Prior to being appointed to this position, Diane served as Director of Comprehensive Mental Health Services and with the Department of Mental Health. In this position, she was responsible for directing the operations of 11 state psychiatric facilities, providing 24-hour acute inpatient care, also rehabilitation and intensive residential care for adults and youth. This unit also directed and she oversaw community-based services provided by not-for-profit mental health treatment and residential service providers throughout the state. Prior to her appointment as the Director of the Comprehensive Mental Health Plan, she served as the Executive Director of BJC Behavioral Health and St. Louis Mental Health Center. She's actively engaged in her community and has some exciting things to tell us about what Missouri is planning for the future. Diane.
How do I get my
Let's just say no. And then if we go here. Yes, very good.
Thank you for the opportunity to be here, especially to speak about something I'm personally very passionate about. Danny gave you a good overview of the current state of the state, I think, with mental health, and especially in Missouri, and has been a real partner in working with us as we move forward with our transformation initiative. So what I'd like to do is give you just kind of a state of what we're doing with regard to mental health transformation, what it is, and kind of where the priorities are right now. Just to give everybody an overview, Missouri had, Danny mentioned that we're the 8th ranked state in getting SAMHSA funding, and we managed to do something on a grand scale. We are one of 9 states that was awarded a mental health transformation grant by SAMHSA. And as Danny indicated, we've gone forward and we've tried to organize across departments because there are actually 7 state departments and God knows how many divisions of those departments that actually provide mental health services. So it's not just the Department of Mental Health. Governor Blunt established a 24-member transformation working group by executive order. This group has the 7 state departments. It has the office, it has OSCA, it has consumers, it has family members. It has currently no providers of care, but it's the state departments coming together, anybody that's involved in mental health at the state level. And our goal and our order that we've been charged with is to develop Missouri's first comprehensive mental health plan that does transcend state departments. We've focused on the Department of Mental Health has always had a plan, but if mental health is provided in the Department of Public Safety, if it's provided in corrections, if it's provided in the Children's Division, the Division of Aging, there are mental health services provided across all departments. And so this is Missouri's first opportunity to say, we're going to create a plan for our mental health that transcends all those departments. And begin to eliminate, because, God, it's a long road, the fragmentation that exists across the departments that really impacts down at the consumer level. This builds upon work inside the department. Many of you are aware of some of the legislation that passed and some of the recommendations that came from the Mental Health Commission, the Lieutenant's Governor Task Force that was really focused on safety. And, you know, the first thing you got to do is assure no harm. But the transformation really takes this to the next level. That's the planning that we're engaged in now, is saying we got to go beyond providing safe care. We got to move to providing effective care that's really consumer and family driven. It also builds upon the work that's already been done in the state with children's services and the passage of Senate Bill 1003, which many of you may be familiar with. And that came about as a result of, with kids in Missouri as nationally, parents were having to relinquish custody of their children just to access care. And I think what's been brought up before is it's very ironic that oftentimes you're entitled to mental health care once you get in the prison. Once you get in, then you're entitled to it. Once you get in to social services, you're entitled to health care and mental health care where you're not if you're outside the system. But the children's plan went a long way, and we're building on that. Now we're taking it across the lifespan, because one of the areas that Missouri definitely doesn't do well on is justice to our older adult population, which is growing. And we have, from the grant that we received, we have about $11 million over the next 5 years to build funds for infrastructure. It's planning, it's workforce development, it's evaluation, and it's technology. So that's really the opportunity we have right now in Missouri. this is not just a Missouri problem. This is a national problem. And Danny quoted Mike Hogan, who is the chair of the New Freedom Commission, earlier. This is another quote, and I thought it kind of summed it all up. The United States mental health care system is described as a patchwork relic, the result of disjointed reforms and policies. We have an unintended conspiracy, and I use the word unintended, unintended conspiracy to keep people disabled. And I think the patchwork relic talks about we have done many reforms, and we've done them in various different places across various different departments, and you tend to have a layering effect that becomes less and less efficient and less effective. What are some of the issues? And many of them have been discussed already, and they're going to be discussed further, but I just want to highlight a few that we're taking to heart in terms of how do we solve these how do we come up with solutions to these issues. First is high rate of unemployment, homelessness, and poverty. Persons with cognitive and mental retardation, mental illness, have the highest rate of unemployment and the highest rate of poverty of any disability groups. And yet, at the same time, we know we have good, solid research and solid evidence-based services that can support people in working, and we further know that people want to work. So why do we have this very low rate of unemployment that continues the cycle of poverty? High mortality rates, Danny mentioned that. Suicide and preventable diseases. Dr. Parks, who I just saw walk in the room, hi Joe, had recently published study regarding persons with mental illness, and it was pretty shocking. We all knew that they had a lower than average life expectancy. But the report for people that were within the public mental health system is 25 years less than average. So when you think about people, and it's because of preventable health problems. Then involvement with the legal system, I think you're going to hear more and more about that. You already have. The Department of Justice report talked about 50% of people have some kind of mental health problem when they're in the prisons and jails, and that it's even higher with regard to substance abuse. School failure and out-of-home placement. Although we've made strides with regard to kids services, we have a lot further to go. People are failing in school. There continues to be out-of-home placement, yet we know building resiliency within the family and in natural environments is what keeps kids healthy. Increasing use of emergency room and institutional care. If you looked at Missouri and you just looked at the emergency room usage for mental health related disorders, it's just continued to rise over the course of the last few years. And it's a constant rise up. And so we know that we've got gaps in care, and that if people were getting services earlier, that they would be able to actually, that we believe the emergency room rate would go down. Stigma, that I think I can't say it any better than Pete did, but that we did a stigma survey in Missouri, and that is continues to be a huge issue. Yet we have made great strides, but it continues to impact it continues to impact access to care. People are afraid to go to care. People are afraid to tell their employer. People are afraid to tell anybody that they have a mental health issue, and they often don't seek care until they're actually in an emergency situation. And then the fragmentation and gaps in care. If you've got 7 state departments, and I want to tell you, you've got 7 national federal departments as well involved in mental health care, all with their unique rules and regulations, there's tremendous fragmentation. And where it really hits is at the bottom line, front line level of people trying to help people, but they've got so many different rules that they're following that they can't even keep track, and it doesn't really meet the needs of the consumer. So basically, I think with those issues, there's lots of national attention. We now have lots of Missouri energy, I feel like, put into this effort. We really must transform. And this is from the Institute of Medicine report, Crossing the Quality Chasm, 2001, but there's been several national bodies now, including the Business Coalition, which represents Fortune 500 companies, that have said we must transform. And as you can see from this picture, this kind of signifies we had the tragedy in Minnesota where a bridge collapsed. The infrastructure was a key issue there. And with mental health, we're fortunate to have a grant in Missouri that provides some infrastructure funding, but the mental health system, just as bridges and roads, needs to have an infrastructure that's maintained and sustained over time. So I'm going to just talk briefly here about Missouri. I want to tell you what our vision is, and I think the word hope was used quite frequently in Pete's speech earlier, and that's what it's all about. It's been talked about all across the state now. Our vision is communities of hope. Throughout Missouri, support and sustain a system of care. We're promoting mental health and preventing disabilities as common practice. That's something we don't do well here in this state. And that everyone at any stage of life has access to effective treatment and supports essential for living, working, learning, and participating fully in the community. We have been going around and asking Missouri consumers and families across the state. We have hundreds of, probably up to 1,000 now, individual visions of what a community hope looks like. I'm just going to share a few, but I think they sum up what our task is about. In a community of hope, my child will be valued as a person who can live, work, and worship without being stigmatized as the mental one or the retard. Somebody would notice the onset of my mental illness. Mine occurred in college while living in a dorm, and nobody noticed. Schools, mental health agencies, community organizations, justice system, etc., would all work together with clients and families. The public is educated about mental illness, and there is no stigma. People see me as having a purpose in life, intelligent enough to work, and capable of responsibility. There would be mental health support for my son when he is in school. And a final one, there is no fear of improving, just enough to lose my services and then needing them again. I would be able to get services before I try to commit suicide and need to be hospitalized. That's just a brief summary of all the statements that we've gotten across the state. There's been a lot of focus on employment, on housing, on just feeling the need to be a part of a community. So what we've done is we've taken a lot of these comments, we've done a lot of work. These are the New Freedom Commission goals of which we've organized our transformation initiative around in Missouri. They include that mental health is seen as essential to overall health and that all Missourians view it as such, that the system is consumer and family driven, that disparities in mental health services are eliminated, especially geographic and cultural disparities, that there's easy, early access to mental health services, excellent services, and accelerated research. Danny talked about evidence-based practices. We have a serious research gap. We have research that comes out that proves something effective, and it may be put into practice 20 years later. We've got to close that gap. And then that technology is used to access services and information. Excuse me. What we've done is we've had, in Missouri since January, we had approximately 240 people that actually participated from all sectors of government, private sector, providers, consumers, families, come together, and they organized and actually came up with recommendations related to each of the 6 New Freedom Commission goals. And what came of this, and we've since done now 14 public hearings, and we've had over 400 people attend the public hearings and give their input and solutions, as well as hundreds of people that have responded via mail or our website. And the strategic themes, the common themes to actually transform Missouri is that we need to move from what's been traditionally a disability focus. We have focused on individuals. We've focused on those that are most disabled. And we need to move to a public health approach. A public health approach that encompasses prevention and early intervention and mental health promotion as part of our overall system. We need to move from the bureaucracy and provider-driven care that exists now to true consumer direction empowerment, putting people first in the treatment planning as well as making sure that their input is what drives our policy making. That is critical. They're the ones that know best. We need to move from pockets of excellence. We have heard about evidence-based practices in something that's really happening really well down in this area of the state, and yet nobody else has even heard of it. Yet it's producing these great outcomes. We haven't researched it. We haven't said, all right, now how do we bring it to scale and make it available across the state? So moving from those pockets to how do we get to universal best practices? And then moving from the fragmented system of care, which is what I call the patchwork relic, that people have to navigate, to collaboration and integrated care. And then finally, Missouri's biggest mantra, I must say, as we went around the state, is nowhere to go. We have nowhere to go. We get bounced around all over the place. We have nowhere to go. And where do we end up? We end up in the prison. We end up in the jail. We end up in the emergency room. So from nowhere to go to easy, early, and equitable access to local care. From the result of the public meetings, we're adding a sixth strategic theme, and that is going from centralized decision-making to shared local and state ownership and investment. And I think your next presentation is going to be about a local initiative, and it's only if we bring the state together with the local and work together can we really solve these issues. It has to be solved at the local level. We heard that, and people want to get involved out there. So our timeline in ending here is just to let you know we've had the work groups meet, about 240 professionals. The transformation work group set initial priorities, and those priorities are in your packet. So you can see them organized around those themes that I just talked about, and these are the priority recommendations. We obtained the public input, and we've completed a fairly comprehensive needs assessment, the first phase. So right now where we're at is in the process of updating this, revising it based upon the public input in the needs assessment, and our goal is to complete the plan and organize implementation teams by January of this next year. We'll be moving forward. Some will be very department specific, Department of Mental Health, Social Services. Others will be we'll probably have about 10 cross-departmental teams working on specific issues. And there are some related budget items this year as well. So that is kind of, in a very short order, the status of kind of where we're at right now. And we've got a website. Everything, every step of the way has been, we have people here that's served on some of the work groups. But all of the work that's been done to date is available on the website, transformation@dmh.mo.gov. And it should be in your packet, so feel free to review the whole plan, all of the recommendations, and we'd love to add you to our mailing list because we really need we need you, we need everybody, and it's all about hope. And I'm really feeling the power of the community. The community meetings was amazing because they instilled hope in me, and it was just so reinforcing. So. We have a plan, and we're about to engage on a journey, and I hope you'll all join us. Thank you.
I did it. Thank you, Dan. That was tremendous, and it looks like the state's moving ahead quickly and with very dramatic goals in front of us. And now we get to hear about a local initiative. One of those signs of hope. Commissioner Marcia Campbell will be speaking with us next. She obtained her bachelor in business and public administration from our alma mater, University of Missouri Columbia, and then her master's degree in political science from University of Missouri Kansas City. She is currently the chair of the Jackson County Mental Health Court Commission and the vice chair of the Jackson County Mental Health Levy Board of Trustees, where she's also serving as the Appropriations Committee chair. She served previously as a representative from Missouri State from 1997 to 2004, where she served as the chair of the Joint Committee on Administrative Rules and the ranking member on the Budget Committee. She also served on the Mental Health and Social Services Appropriations Committee and the Criminal Law Committee. And she's here to tell us about the relationship between mental health and corrections. Welcome.
Thank you. I want to talk a little bit about the relationship of, as Chris said, mental health and corrections, and then I want to tell you a little bit about what we're doing locally in Jackson County. The Bureau of Justice Statistics did a survey in 2005, and they found that 64% of those in local jails, 56% of those in state jails, had a serious mental problem. Now, folks, how did we get here? What happened here? Well, Pete Early talked to you a little bit about this, but I'm going to show you the picture. And here it is. If you look on the bottom, on the left, that is our prison population. This starts in 1928, and it takes you up to the year 2000. The middle line is mental health institution population, 1928 to 2000. Check that out. 1974, they just cross. They cross. Danny talked a little bit about funding and what's happened in mental health. Mental health funding has gone down. Correctional funding has gone up. They've crossed also. This is the literal definition of whack-a-mole. We have taken mental health folks with mental health problems, and taken them out of institutions and put them in jail. And the funding has followed that. The funding has followed it. An example is in Northwest Missouri, we've lost 2/3 of our psychiatric beds since 1990. So there isn't any place for people to go except jail. 15% of Missouri prison inmates have a serious mental illness. Commonly, schizophrenia, bipolar, major depression. Do their symptoms get better while they're in prison? Oh, no. Nope, they get worse. And then they get out. The Department of Mental Health, by its own admission, has no coordinated plan for reentry into the community. Now they're trying. There's some things going on with the departments, not necessarily through the transformation, but it is all kind of runs together to get some things done. But it's not there yet. It's not there yet. So those folks who have these problems are coming back into the community. And, of course, the correction system sees them again. They don't just come once. Okay? At the state level, they will reoffend within 5 years. 34% recidivism rate in the state of Missouri. It's awful high, awful high. So what are we doing in Jackson County to try to work on this? Well, for one thing, we're working in the detention center, which is the pre-trial facility in Jackson County. Look, there's a little teeny line here, and it says the largest mental health facility in the region. We're not any different than LA. The same is true in St. Louis. It's true in other places. So we're trying to do some work within the correctional facility. Our levy is spending $415,000 a year for case management and psychiatry within the facility. Within the facility. The county actually spends $90,000 a year for medications, mental health only, within the facility. And then we've tried to get other agencies that we deal with to come into the facility, such as Veronica's Voice, which deals with prostitution, to come in and work with people also within the facility. Because if we weren't doing this, nothing gets done. Nothing. Oh, might keep people calm with some medication. But that's it. That's all that's going to happen. Okay? In our local city jail, Kansas City Jail, we're spending $263,000 for case management and some women's groups, which are kind of fun. We did a survey and found that of those folks, the number one thing they needed when they got out was housing. There just isn't any. Many of them are homeless. Many of them have nowhere to go once they've been in jail. So we're spending $20,000 for 3 transition beds at Restart, our local homeless shelter agency, to see if in a very teeny tiny little pilot, if we can help some folks coming out of the municipal jail to have housing and to get on their feet and not come back, obviously. We have a collaboration going on there at the jail with the Healthcare Foundation, who've been great, UMKC, Connections to Success, and our local hospital, Truman. All of it is very, very much a pilot program, and we're doing extensive evaluation to make sure that we know what happens with these efforts, and we know exactly what happens with these efforts. So that this isn't, it's easy for all of us to say we know what should happen and we know why. It is so much more helpful on funding and in terms of getting our story out, especially to legislators and others, if we have absolutely rock solid data on how these programs work. One of the other things we've been doing and been very supportive of is crisis intervention teams. I think Pete Early talked a little bit about that. That obviously trains and certifies law enforcement response to the mentally ill in crisis. We spend $93,000 for the evaluation of that program in Jackson County, and it's another instance where we can prove how good this is. We can prove it. And law enforcement in Jackson County has bought into this thing lock, stock, and barrel. They have a waiting list at the Kansas City, Missouri Police Department for officers to be trained. They sign up, it's voluntary, they want to do it. In Lee's Summit, they actually schedule their officers based on their CIT calls. Pretty cool. Most of them come, by the way, Wednesday afternoon. Go figure. It leads to fewer injuries, both for the victim, but for the officers and for the person involved. And it leads to lower arrest rates because trained officers will find the person help, treatment, as opposed to throwing them in jail. Those referrals are really important, and it's part of the whole communication system and trying to get, and Diane talked about this a little bit, it's easier for the local folks to chat with each other than it is for folks to try to talk, at a more global, statewide level. That's just harder. But these folks see each other every day, and it's a little bit easier for them to get those lines of communication open. And I think that's part what you're doing in your transformation is trying to assist that as we go along. And then our third initiative is mental health court. You're going to hear a lot more of that from the founder, one of the founders, Judge Williams, here in a minute. But we spend $165,000 on monitoring and assessment. Did that change? There we go. $60,000 for legal defense through legal aid, $200,000 rapid response through our community mental health centers, $87,000 on evaluation. There's the magic word again, the evaluation. Rock solid, every quarter. We know exactly who's been through. We know for a fact that only 14% of them reoffend. We know that. Versus 34% for the state. So we know that. It is a public and private cooperative venture. The city of Kansas City, courts are in the city of Kansas City, Lee Summit, and through our drug court. So it has really been a terrific program, and all three of those things wrapped around together are very solid local initiatives that can help feed into this system and try to keep these folks out of jail and in the community where they belong. At a local level, I think we can do a lot through community leadership and leveraging of resources. Every time we talk to somebody, we bring somebody else into the group. And some of our groups are getting quite large. Our Mental Health Court Commission we've about outgrown our conference room because so many people want into this thing. It's really, really interesting and fun. We can encourage national best practices, and we can engage community leaders. Why would we want to do all this? Well, not because we're involved in Hug-a-Thug. That's not what this is, okay? And Hug-a-Thug is quite a word that floats in the community. You all may not hear it, you're professionals. But you're out there on the street, and that's what they'll tell you, okay? But that's not our deal. This makes incredible economic sense. We can treat at the community level in Kansas City, in Jackson County, $7 a day. $7 a day. Got it? What is it at the state level? 70 to put somebody in prison? So the money issue is bogus. Somebody says it costs too much, they're wrong. They just lied to you big time. And there are a lot of studies out there that show this. We're promoting public safety, okay? Law enforcement doesn't get hurt as much. They have time to go after the real bad guys instead of worrying about some poor homeless fellow who's out there delusional on the sidewalk. It's absurd. It is the right thing to do for lots of reasons, but with treatment, 86% of the offenders go back into the community, live a regular life, just like you and me. What's not right about that? So we can do this, and we can do this together. We can do it at a local level. I think you'll hear more about the mental health court system and all the good that it's doing. And I think as we all work together, we can help this. But you've heard this a couple of times. This isn't cheap, but that doesn't mean that it's not better. And it doesn't mean that we don't save money elsewhere, because we will. We have to get our act together enough as advocates to prove that. And I think a lot of these different evaluations that are going on, a lot of what Diana's finding out through the transformation, is going to show us that and allow us to get in front of legislators and elected officials and say, hey, you know, you got to put more money back into this system. They took it out. They took 5% out, according to Danny, and you know, I trust him. I think he's right. I was there. I saw it. But it's got to come back in, and we've got to use it for all the right reasons instead of using it to simply warehouse people in jail or prison. It's absurd. We're not getting any use out of these people. They're not helping our economy. They're not helping you or me. They're just sitting in a building. That's dumb. We can do better. Thanks.
Oh, all right. Sorry, I need to go down there. There we go. Okay, very good. It's now my great pleasure to introduce Honorable John B. Williams, who graduated from the University of Missouri, Kansas City, with a bachelor's degree in economics in 1970 and from the UMKC School of Law in 1973. He served as a Kansas City Assistant City Prosecutor from 1974 to 78 and as Jackson County Counselor from 1983 to 1991. He's also been in private practice at various times. He was appointed judge of the Kansas City Municipal Division of the Jackson County Circuit Court in 1995. He served as presiding judge in 1996 to 1997, and again from 2000 to 2004. He's presided over Kansas City's Mental Health Court since June 2002. He served on the Board of Governors of the American Judges Association from 1998 to 2006, and on its executive committee from 2003 to 2004 and 2005 to 2006. Tells you a lot about the tremendous career that Judge Williams has had, but here's something about his character through his career. He received the National Alliance for the Mentally Ill of Greater Kansas City's Community of Service Award in 2002. He was recognized for his community leadership by the Jackson County Mental Health Court Commission in June of 2006, and he received the Judicial Recognition Award from the Association for Women Lawyers of Greater Kansas City in 2006. and he's here today to tell us about mental health court. Judge Williams, welcome.
Thank you. It's good to be here. What I'm going to attempt to do this morning is share with you a thumbnail sketch of our experience in Kansas City with our mental health court. And the journey of our implementation of the mental health court began in 2001 when the Jackson County executive appointed a commission. The membership was drawn from throughout the community. There were city and county officials, police officers, mental health consumers, mental health providers, local jail officials, prosecutors, and judges. And we started out talking about a mental health court at the circuit court level, but as time went on, we decided that we would concentrate at the municipal court level. And that was supported by the types of numbers that Marcia gave you about the incidence of mental illnesses in the Kansas City Municipal Correctional Institution. We call that MCI, so if I lapse into that jargon, you'll understand that. That is both a detainee facility where you sit awaiting trial and the sentence facility where you are serving your sentence if you happen to be so confined. And the operation of the mental health court actually began in 2002. It was originally funded with a half-cent sales tax, a portion of that had been imposed by Jackson County residents upon themselves for anti-drug purposes. That's called the combat tax. That's a community-backed anti-drug tax. And also a property tax levy that was funded also by Jackson County that went through the Jackson County Mental Health Levy Board. And since then, the Healthcare Foundation of Greater Kansas City has stepped up to the plate and now is funding 31% of the operation of the court. When we set up the court originally, we thought there were there are two things that were real important. And monitoring is obvious that you needed to have that, but we actually started with evaluations of the program. The outside entity that came in and saw what was going on and recorded it, we started with those evaluations before we even had the court in operation, so we can go back and track through the discussions and who was involved. In fact, I wasn't even on the original list of commission members, but it was when they decided that Jackson County Circuit Court wasn't the right place to be because their offenses were too serious for this type of operation. They decided to come down to the next level, which would be the Kansas City Court, and that's when I was invited. Later on, we invited a judge from Lee Summit. The monitoring is provided by a staffing entity that contracts with the county that came in from requests for proposals, and something that we didn't have at the very beginning but now is crucial to the operation, and that's why we had to add it, was legal aid defense. In Kansas City, what you might call a public defender in some other portion of the state is handled by Legal Aid for Western Missouri. They have a special municipal court unit. And we were trying to make do with just their regular staff, and that clearly wasn't working. And so we went back to the commission. The commission went to the Mental Health Levy Board. We got more money to hire a part-time lawyer, and since then that has changed to a full-time lawyer. And in a moment I'll touch on why we think that is so crucial in the operation. In Jackson County, we have two municipalities, Kansas City and Lee Summit, that have mental health courts, and there's also a mental health track in the Jackson County Circuit Court at the drug court level. Today, I'll be talking primarily about the Kansas City Mental Health Court and the way we have the practices there. A mental health court is a type of court like a drug court or a domestic violence court or a housing court that is approached with a concept that was formerly known as therapeutic jurisprudence or restorative justice, but which has now been named by the Conference of Chief Justices of all the states and the Conference of State Courts Administrators as a problem-solving court. And when we set up our original problem-solving court, we made a determination based upon the recommendations of the Community-Based Drug or Mental Health Court Commission that the program be a diversion program. Also, that it be a voluntary program. So it's not going to be after someone is convicted. It's not a condition of probation. It's pre-adjudication, which means it's before the judge makes a decision on the case. It's even before trial. No evidence is heard, and it's even before a plea is required. So a person doesn't have to say anything about the actual offense. And the program is voluntary in that not only the prosecutor, who is pretty much the gatekeeper to the program, because she is going to have to be the one to decide whether the case is going to be dismissed at the end or not. So not only the prosecutor and the judge have to agree, the defendant has to agree to participate in this voluntary program. And if the defendant does complete the program successfully, then the charges against the defendant are dismissed by the prosecutor. Now let's go back a minute and see how a case actually gets to mental health court. In Kansas City, the cases that are filed that land a municipal court are called ordinance violations. That is, violations of city ordinances. And these ordinances usually track state criminal statutes. In fact, charges could often be filed at the state level as misdemeanors or sometimes even as felonies, but for a variety of reasons, their charges are filed in city court. And the charges are initiated by a police officer when he or she makes an arrest. Now, as Marcia mentioned, we have CIT officers. So frequently and hopefully, in the best instances, the officers don't even file the charge. They don't make the arrest. They diffuse the situation, or if the person is in need of immediate mental health services, they take the person to a facility. Usually in Kansas City, that's Western Missouri Mental Health. But if for some reason the charge is filed, then that case gets into the system. And throughout the system, there are a number of areas where the potential for this case being in the mental health court system as opposed to the rest of the docket of the court, these can be identified. Now, the types of charges that you have are such as trespassing, stealing, destruction of property, disturbing the peace, disorderly conduct, assault, urinating in public, prostitution, possession of drugs, possession of drug paraphernalia, hindering and interfering with an officer, resisting arrest. So there's a whole panoply of charges that can come to city court. And if you think about those charges and you think about the types of issues that the people that are going to come into court are dealing with, you can see that there is a large overlap in people with mental health issues that are going to be charged with these cases. So then the question is, how do you get the case into the mental health docket? Well, you've got the arresting officer who can schedule it there if he or she thinks that's appropriate. You've got the booking officer who can flag that case for attention further down the line. If the person doesn't post bail, they're held overnight in the Kansas City jail, and other officers who weren't out on the street and didn't book them in have the opportunity to interact with them, might and frequently do notice that there's a problem. When they're booked in there at that jail, that's the central holding facility, so that's not usually where they're originally arrested. They have a form that they go through and check out and ask them questions about prior mental health issues, whether they've had prior mental health services, whether they're in services anywhere else. So that if they haven't posted bail, by the time they come up for arraignment the next morning, that's done on a video basis from the jail to a judge in the Kansas City courthouse, the judge there can be alerted or can detect on her own whether this person might be a candidate for the court, and those cases are then brought over that very day. Other cases come into the system because the defense lawyer or a judge or a prosecutor or a victim or the attorney for the defendant or a caseworker for the defendant alerts somebody in the process, and the case is referred down to the mental health court. Now, how the mental health court then deals with these cases is, as soon as the case comes in, we try to find the legal aid lawyer. That's why it became so crucial that we have someone who is working just on the mental health cases. Now, we do have to share this lawyer with Lee Summit and also with the mental health track in the Jackson County Drug Court. But that's a simple scheduling problem, and as long as we know that the lawyer is going to be available, we can make scheduling adjustments. So what happens, as a practical matter, is every day I see 2 or 3 people that are referred to me, either that are in custody, either that have just been noticed that morning as having an issue and being brought over from the Kansas City detention facility, or they're noticed in another courtroom. Either they have posted bond, or they may still be in custody because the problem wasn't detected the day before, or the week before, or whenever it was. So then they come down, and we have the legal aid lawyer meet with that defendant. So right away, at least as soon as we've been able to alert ourselves to the problem, they're able to get an unbiased explanation of what the program is. Because I, as a judge, can't really get into evaluating for them whether it's a good decision for them to make or not, because I can't hear the evidence. I can't ask them about their past background and all. But their lawyer can do this for them. And so when it says here that sometimes there's an evaluation or a plea, that's because they may decide, this is just a trespassing offense. This is your first offense. You're going to get time served or a fine or a very minimal probation. Maybe you're better off to not go through this 6-month to a year program. And they can make that voluntary decision then based upon the information that is provided to them through their lawyer, and they can sit down and evaluate the situation. So if they determine, yes, they want to go into the program, we've now got the referral that came from someone. The prosecutor makes an initial determination, yes, it seems okay. They're going to now be scheduled for a screening appointment. We use Swope Parkway, which is now Swope Health Services. That's the agency that's on a contract to schedule the court monitors to meet with these people. And then first there is an assessment, and then later on, if they successfully clear that assessment, then there's going to be an evaluation. So we have a list of court dates. We have a list of appointment dates. So we put those two together and we say, all right, you're going to meet at Swope November the 22nd with Wesley at 2:30, and you're going to be back here in mental health court November the 27th at 1:30 in courtroom A. It's all written out for them on a pre-printed form that, well, actually we've got it computer generated now, so it's fresh each time, and it's not even handwritten. And if they're still in jail, we make a determination whether they should get a signature bond or not. And if that situation is appropriate, they'll get the signature bond, and then they'll come back to court. There's some people that we're not quite ready to let go yet, so we'll have what's called a rapid response, and that can mean all kinds of different things, but here it means they come down to the jail and evaluate them, and then we come back in a few days. Sometimes the situation is so dire that they're in immediate need of mental health services, so they're sent to Western Missouri Mental Health Center. So frequently after medication, they come back, and then they're able to talk with their lawyer and make a determination as to how to proceed on the case. So if they come back and they've completed the assessment and they've completed the screening, then they are admitted to the program and they're given a particular treatment plan that's been determined as a basis, based upon the assessment and the screening. And they're going to be in the program 6 to 12 months. Now, the average of somebody in it, whether they complete or not, is 11. So you can see there's lots of false starts. Because really we're asking for 6 months of good behavior in the program. And if they have a problem, like missing screening appointments, or missing their court monitoring appointments, or missing court, there's going to be some more time likely tacked on. And if they have a situation where, as they frequently do, have drug issues, and they don't come up with a clean urine test, then they're going to have an additional 3 months, because we always require that there be 3 months clean urine at the end of the program. Then if they successfully go through all of these steps, they come back, they completed the program, they graduate, and the charges against them are dismissed. The slide before you now shows briefly what the occurrence of the different types of diagnosis are. The dual diagnosis is 49%, which means almost half of the people that are in the mental health court program that have been accepted and diagnosed have drug issues. Schizophrenia at 29, personality disorder at 26, and bipolar disorder at 26, depression at 15, mental retardation at 4. So you can see we run the gamut. The statistics that are in the next couple slides and in the other handout have also been covered by Marcia to a fair degree. So I'm not going to take much more of your time. You can look at the materials there, and it will tell you about that. We're working to get continued collaboration between the justice, corrections, and mental health systems. One of the real advantages to this program is that I can get people on the phone now that I didn't even know existed before. So we've got resources to deal with problems, and we're continually getting into more and more areas on this. And people are starting to look at our problems as if they're theirs, which is great. We're working at integrating new treatment and changes at MCI for the reentry, because not everybody goes successfully through the program. And you're going to have some people that just aren't ready to do it or aren't capable of doing it. They just can't quite handle showing up for their appointments. Other things are more attractive, or their day planner battery went dead or something. I mean, these people are not that structured until you get a good chance to work with them. We're going to be working more with the homeless, because we found that homelessness indicates that someone is twice as likely to successfully complete the program if they're not homeless. So we know what we need to do. It's just a question of how we deal with that. And we're going to concentrate more on the higher risk clients. And we're probably talking about expanding into independence. The program's in operation. It works. It has a positive effect on those who participate in the program. It encourages collaboration between city, county governments, state government, and the stakeholders throughout the community. Thank you very much, and I look forward to answering your questions.
All right, very good. Thank you, panelists. Tremendous set of discussions. We're going to have a few minutes for questions, if you have any. We've got microphones here, so wait till you get the microphone before you start your question. And you can open this up to any one of our panelists.
And my question is directed toward, now it's on, Ms. Campbell. Could you talk a little bit about the 200, let me see if I can find it, in your presentation, 200,000 rapid response. Could you talk more about what that is?
Yeah, it is, can you hear me? No. It's for our community mental health centers. And as the judge said, if police, this can be something that law enforcement accesses in terms of somebody needing immediate care but not being severe enough to go to Western Missouri Mental Health Center. Or more typically, it is something that is used through mental health court to get them immediate assessment rather than waiting. You don't just decide that you need to see a psychiatrist and get in this afternoon. Doesn't work that way. Doesn't especially work that way if you're poor. So this is an attempt to make sure that within 24 hours they get assessment in a community mental health center. And it pays the provider to do that. It comes from our Jackson County Mental Health Levy, our property tax.
There's a question up here. Jordan's coming to you with the microphone.
My question is about the evaluation. I think you've done a really nice job in looking at the impact, the outcomes, and I'm wondering if your evaluation includes looking at the process pieces. I know you talked about recognizing some target at-risk people that don't succeed. What your evaluation is in terms of looking, the formative piece of the evaluation in looking at the process as well as the outcomes, because I'm thinking that could be used by other people to see what pieces of that work and well and what don't work as well.
Yes, it does. The evaluations are done quarterly, although there is a monthly fact sheet that deals with just the numbers about what's going on. And in each of the quarterly reports, they usually focus on one process piece. For example, to find out what percentage of the people in the community mental health centers are aware of the mental health court, and if they've used it, and what their experiences are with it. And they do that with various things. They've got one, I don't think they've done it yet, but like with the court system, to check with the other judges to see, who's doing what. And then they'll find, okay, then they'll have recommendations on that, such as, we find there's low usage here and low knowledge over in these other areas and high here. We ought to figure out what we're doing and try to do that. So yes, there are some recommendations on that. And Marcia, those evaluations, are they available online?
I'm sure they are through the Mental Health Levy can get it for you, which is jacksoncountycares.org.
Good question.
Yes, this is for Judge Williams also. As a healthcare provider, I'm a primary care physician. We oftentimes see these individuals before an event actually occurs, either in the clinic or in the hospital, and they're at high risk. Is there an opportunity for someone like myself to refer to the system, to the court, and to the evaluative system before an acute event in a preventive way, to get an assessment and to get an intervention done? Because quite honestly, it's oftentimes difficult to get these folks into a psychiatrist in a timely way at the community level.
Well, fortunately or unfortunately, we're the court, and we can only deal with cases that are before us. And one of the things that I was warned about before this, while we were starting the project, Judge Steve Liefhelm, who's in Miami-Dade County, took me down there and gave me a tour and said all this and said, now, you got to be careful because you don't want to criminalize access to mental health services. But all we can really do is work with what we've got. Now, if that person hasn't had an acute event but has a pending case for something that, is not so terrible, not life-threatening, they can come in through that process. And we frequently do get people that have caseworkers, and we're not going to we're not going to bring all this together just for a parking ticket. We usually avoid the traffic cases. But if they've got something else that's pending, we'll bring that in. So it could be a disorderly conduct or some other charge. I mean, usually that's the case. I mean, it just doesn't escalate all of a sudden from nothing to this terrible acute event. And so if there's something there, they can come in on that. And one thing that I didn't mention is we bring all their other charges in together so that even if you've got your traffic tickets, you're not having to come down here except once a month. You don't have to come down, 3 different times because you've got 3 different cases pending. We roll them together. So I can't help you with that. But there might be some, we're identifying these things as ways to deal with it, and, our funding is for certain specific purposes, and so we have to kind of work with that.
A couple more questions here, and then, Dr. Rowland has the microphone, so we'll take him first.
Diane, how much more money would it take to complete the Missouri Transformation Project, all of the kind of the before and after slide that you showed, to get to that right-hand side? How much money are we talking about?
I don't have a figure on that. And one of the things that we're engaged in, when I said we were doing a needs assessment, we're also doing a current inventory of resources. And let me tell you how difficult that is trying to identify what resources are actually going to mental health and where, and how to reorganize them, because that's got to be part of the strategy that we do. The other is what's the need versus what's the total resources available, and what's the gap. That's probably going to take us at least another year to get a good picture. We think we have Department of Mental Health, we have Medicaid in some areas. I know in the Eastern region, the Regional Health Commission did a really good resource inventory. So I think until we have that totally complete, I can't answer that question. And it's been difficult because clients don't have a single identifier. That's one of the recommendations we have, is that anybody that's receiving services across at least the state departments have a single identifier so that we can even see who is actually receiving and using services across departments. So that's part of at the state level, a change we have to make so that we can make good, rational decisions. But I would imagine there's a lot of money in the system that if we did something a little different, if we studied it and used good evaluation, we could make better use of it. But there's also, we know there's a real gap in actual funding as well. So it's a combination of those two.
Very good. Last question here, maybe?
I was just wondering if there are other mental health courts throughout the state, and if so, where they're located.
Well, Lee Summit has one. I think there's something here.
There's Columbia and St. Louis.
Right, I say here. I guess I drove past
Springfield.
There. Green County.
Yeah, Springfield area, Green County area. I think those are the major ones
right
now.
Maybe a little advocacy work that we could do for all of us.
That's a goal.
Expand
statewide.
Statewide is a goal.
CIT and statewide mental health courts.
Excellent. Well, I'm going to stop there and thank the panel again. This has been a tremendous discussion about our needs in Missouri and the things that we're doing to accomplish the goals that we've set before us.